If you're enjoying the Next Breast Thing podcast, be sure to leave a rating and review where you listen to the show. Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
based on my previous goals where I talked about doing the cold plunge every day,
I am so excited. This will be my first ASBRS conference that I've ever been to.
Kind of a silly update. Most people don't know this about me, but I love it.
The cow is getting bigger. I'm fairly convinced that now my cow is in fact pregnant.
Getting ready for ASBRS. In preparation for that, I'm brushing up on my CRAPS skills.
Today's topic is how patients can mitigate their cancer risks in 2025.
I remember when I was growing up, smoking on an airplane was the norm. And I think that alcohol is really going to be part of this discussion coming up. What do you guys tell patients or tell primary care providers that you might be talking to in terms of how much alcohol you can drink? Or should we not be drinking alcohol to prevent breast?
This patient's drinking 2 glasses of wine every night with dinner. What do I say?
one thing that I don't discuss that I want to, because I think the evidence behind it is very compelling, is...
So let's talk about something that we know is causal.
This is Carla,
Ellie,
Michael,
Susie,
Sitcha,
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
from advances in procedures and patient care
to personal transformation. We're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
In today's episode, we'll be talking about how patients can mitigate their cancer risk in 2025. But before we get started, let's begin with some professional and personal updates. Ellie, what's new with you?
What is new with me? So based on my previous goals where I talked about doing the cold plunge every day, ouch! I have not done that at all. It's been a little colder here than normal, so I have not jumped on the cold plunge bandwagon. But professionally, my PA has started and I'm just figuring out that working relationship. Kind of gave her a list of tasks and now we're seeing what works, what doesn't work, and then going from there. So nothing that exciting. But Susie, what about you?
Personally, I started to learn how to play mahjong with the ladies in the neighborhood, and it is so exciting to just have that time carved out to do something what I think is normal, because we've sacrificed so much going to work, going home, what's the next thing on the list, and this is just time to enjoy. And professionally, I am so excited. This will be my first ASBRS conference that I've ever been to. I always have a conflict, so I have no idea why I'm on this podcast. I feel like I didn't disclose that ahead of time, but I'm really excited. And I saw the agenda, and I normally am like, oh, I'm not going to go to that. And it looks amazing, so I can't wait to see you all there. Sitcha, tell us about you.
Oh my God, Susie, I'm excited for you. It's such a great meeting. You're absolutely going to love it. I walk away so refreshed and learn so much every year. So I have a kind of a silly update. Most people don't know this about me. I love fantasy football. If I could be a podcast host for fantasy football topic, I would love it. I've been playing for a couple years now, and I won first place in my fantasy football league. And I know it's silly and it's fake, but I'm so proud of my fake team, and I'm so proud of my performance in it. And it's a competitive league, so yeah, I'm super happy to talk about it.
Sitcha, haven't you seen the meme that says nobody cares about your fantasy football league?
What? My prior fellows definitely care, but yeah. Anyway, that's me. How about you, Susan?
I am not a fantasy football person, so I am happy for you, impressed that you won. The office is getting their Super Bowl pool together, which is super cool and exciting. And I hope to win every year, and I never, ever do. But that's okay. On a professional note, one of my many, many, many passions is resident and fellow education. And this weekend, we have the fellows course for ASBRS. So super exciting. We'll be doing ultrasound and oncoplastics. So that's very exciting. So happy that the weather will be nice and warm. Last time I checked, it will be 2 degrees in Cincinnati, and I am so not a fan of the cold, so not looking forward to that. But it is what it is. Carla, you're used to that 2-degree weather these days.
No, yeah, I didn't grow up with that, but
No, I'm saying these days. So I guess I can't complain to you.
it's a tough one. I am getting ready for ASBRS. Looking forward to that. So in preparation for that, I'm brushing up on my craps skills. For anybody who wants to connect with me at the meeting, you can find me at the craps table, winning lots of money, hopefully.
Carla, will you go to Old Vegas with me? I can't find anyone to go because the minimums are like $5. Yes, it's fun.
I have lost so much money in Old Vegas because of those minimums. It's very deceiving.
Otherwise, it's $50 at the craps table minimum, and then you're on the pass line, then you're on the number. You can't do it.
You want to throw...
So we're going to Old Vegas. That's it.
I'm working on that, and then also I'm going to be speaking at one of the pre-meeting courses, so looking forward to that. And I'm one of those people who likes to start working on a talk at least 2 months ahead of time. I think there's people who are like the 1 week ahead of time, and that PowerPoint starts getting made early. So I'm excited.
Can I ask when it gets done? Is it done 2 months ahead of time or the day before?
Whenever they tell me it's due, you get it. I am a rule follower to a T. So if they tell me it needs to be sent in by April 1st, the person is getting it April 1st, and I'm pretty good about that. So
impressive.
How about you, Mike? Are you excited? This is going to be a big meeting for you.
Here's a little fun fact. I have never missed an ASBRS meeting from the very first time that it started in Charleston. So you'd think that I'd have this down. I'm horrified because pretty sure I'm in charge of the one in Seattle, which is 2026.
You are, in case you were not.
Hey, I was hoping I could negotiate that.
You
but
will be.
So now I've got to look at this meeting in a whole new set of eyes. It's going to be a lot less fun and a lot more business. So that's my professional update.
Will you wear overalls?
Oh, man. I was going to ask that.
Well, that blends into my personal update. The cow is getting bigger. I'm fairly convinced that now my cow is, in fact, pregnant. We've had a little bit of time since our last podcast. I'm seeing a little bit more girth to the cow. Hopefully, in the next podcast, I'll begin to see maybe a baby cow.
Michael, I know someone who might want to buy that cow.
It's going to be expensive because it's part of my operation as a rancher.
Wheeling, dealing.
Is it legal? Are we allowed to do cow deals on this podcast? Or
Let's save it for Vegas.
Exactly right. All right, well, why don't we move on to our topic? And today's topic is how patients can mitigate their cancer risks in 2025. Who'd like to get the conversation started?
I don't know if you all remember this. I remember when I was growing up, you could smoke on an airplane, not me personally, but smoking on an airplane was the norm. And then I remembered sunscreen, and it was really only the redheads who took SPF 15. Otherwise, it was like, oh, for your first day out, you need the Bain de Soleil SPF 6. And now it's like, oh, you don't have 50? And I think that alcohol is really going to be part of this discussion coming up.
and you're just going to leave it there. So you hear it.
Let's vote against that as a
And think you have to say about that and what they've done. I think it's interesting if we talk about it. And then what we do personally too. Like I have these recommendations on the bottom of every note. Here's 3 things you can do. Healthy body weight, moderate to vigorous exercise. And then you have to talk about, hey, what does that mean for you? And in Boulder, we have some people who can run a marathon at 80. Not me. Just kidding, I can. But seeing where people are on that and then being able to ask, what does it mean for you to drink alcohol? Or looking at that personally. Are we doing it ourselves? So it's a neat topic to discuss.
I love this topic. I'm so excited we're talking about this. I think it's so important to remember we can actually mitigate cancer risk. We tend to focus on treatments and cure, and there are many ways to mitigate risk. And I think it's important to remember that risk is not just risk of developing cancer, but it's also risk, if you have cancer, of developing advanced cancer. Things just like breast imaging, mammography saves lives. Staying up to date with your imaging can be an important mitigating risk factor for the risk of developing an advanced cancer. And then, we often think about drivers of risk and things like a genetic mutation, for example, and things that really drive risk. But even in those settings where there's a powerful driver, there's still things that can be done to mitigate risk. So I think it's just such an important topic.
I think it's important to frame this topic, and maybe I'm just such a numbers person, in that American Cancer Society estimates that about 30% of postmenopausal breast cancer is linked to modifiable risk factors. That's an enormous percentage, almost a third. So we really can make a difference. We can decrease that number. And I know, Michael, you said on one of our earlier podcasts, can we change that number 1 in 8? Well, yes, we can. Now, can we personally? No, but it is part of our job to educate. The problem is we're educating people who are already in our offices. How do we educate the masses? How do we educate the real population-based education on these issues where, honestly, people don't want to hear about it?
It is important to contextualize what we're talking about. And there's, how do I prevent myself from getting cancer? How do I talk to a patient about that? What Sitcha said in terms of when you have cancer, how do you decrease the risk of it becoming more advanced or metastatic outside of other medications and treatments? And then sort of in that survivorship aspect, how do you help prevent another cancer from forming? Because we know, again, that obesity increases the risk of secondary cancers or recurrences for women who've had breast cancer. And so I think most of what we're talking about is that kind of prior to somebody developing breast cancer, what are things that people can do? So we all agree that not smoking is an important risk factor that's modifiable. I think as we talk about alcohol being something that is newly coming into our world, I think we have to acknowledge, just like you said, Susie, that like smoking causing cancer wasn't necessarily always known. That is something that came about sometime after people were smoking. One of the things that we do have at my center that I'm very thankful for is we have a tobacco cessation counselor. So as we've also talked about, it's easy to say you need to quit smoking, but most people who smoke know that, and they've just found out that they have breast cancer, and the last thing they want to do is quit something that helps with their anxiety. And so I always mention it to patients, and then if they look like they're open to quitting, then we have a tobacco cessation counselor who can talk with them. And if they're not open to it, then we absolutely do not talk about that anymore, and we might come back to that a little bit later. So smoking, alcohol, what do you guys tell patients or tell primary care providers that you might be talking to in terms of how much alcohol you can drink? Or should we not be drinking alcohol to prevent breast cancer?
Now that the Surgeon General came out with this report about alcohol, do we think it will change behavior? I mean, it took decades with smoking.
Yeah, but I think it's already changing. It's actually very in vogue right now to not be drinking. Sober Curious is a huge movement in the health and fitness community. It's kind of fascinating that the Surgeon General released this so recently because people have been talking about alcohol and its deleterious effects on sleep and on anxiety. And the cancer part wasn't necessarily mentioned. And I certainly was educated in that in fellowship. But now that the Surgeon General has said this and it's been in all the news media, I think it will take on even faster. And especially in our social media world where change is happening so rapidly, I do think this could be adopted much easier. Now there's all these non-alcoholic companies popping up. Every celebrity has a different non-alcoholic spritzer that you can buy and have that instead of alcohol. I do think it probably will take effect quicker than the anti-smoking thing.
So hopefully, I just looked up as you were speaking because I was like, really? Are people drinking less? And
Totally.
through August 2024 have decreased by 8%. I mean, that's enormous. Beer, 4%. Spirits, 4%.
Yeah.
Those are enormous numbers. Now, part of it is they really increased during COVID. So
Totally.
it will be interesting to see where it levels off.
A real question is what's your target audience? Because somebody that's older like me, have I already done all of the damage in my life that it's not necessarily reversible? Not that I'm an alcoholic, but I'm just saying at 60, can I really do anything to mitigate significant cancer risks? Whereas someone that's younger than me, maybe in their 30s or 40s, and they've got a lot more runway. I mean, I wonder if we should be looking at which groups we're targeting, that some groups you're just not going to change much. But if you get what Ellie's talking about, sort of the new ideas of some of the younger folks that, hey, look, we recognize that we might be able to mitigate. Maybe even kids in school. Should we be focusing more there so when they're 60 or 50 that they're not dealing with the cancer?
I don't know. I don't think we'll know that, Michael. And I think your liver will still thank you on that. But I think the more we say that and the more it's an open discussion, it's important. I know for the younger kids, there has been a decrease because of social media that people just don't want to have themselves posted in not a good light. And that's a different motivation. But I think for all of us, learning about what is that excess? And Carla, I think you asked, what do we tell people? And I say no more than one standard drink per day, and you can't save them up till the end of the week. And it's better if you do less. And I ask my patients, like, what is it really that you do drink? And it's not a judgment thing. And it's been really exciting to have a real conversation. I know when I was in medical school and residency, it was like, oh, whatever they say, at least double it, maybe even triple it. And just be able to say like, hey, I'm just seeing where you are. And I'll check in with you later. And is there anything more information you want? And I include where the data is on their note. And I suggest there's lots of different ways. So if you love a good bottle of wine and you don't want to waste it, there's a lot of systems now where you can take one glass and a year later, it tastes exactly the same. And so I think giving people those tools is also important, like how to. Susan, I think in a previous podcast, you had referred to, like, you can't just say exercise. Where is the patient? Where are they now? Where do they want to go? And like Carla said, if you don't want to talk about quitting smoking, we're not going to talk about that right now. I'm planting the seed. And then how do I help you get there?
So much of what we do is reading the room, right? And when we're sitting in that exam room or the consult room or wherever we speak to patients, it's reading the room. If we've just told them, this woman sitting in front of you, that she has breast cancer and you're going through all the treatments, talking about alcohol, probably not the right time. There's a time and place for everything. And that's one of the incredibly important parts of survivorship, which some people will say begins at the first day of diagnosis, survivorship begins. So it's figuring out where to fit these conversations in. Now, smoking, absolutely. Good time at that time of discussing surgery because it impairs wound healing. So that's okay. But as you said, if you harp on these things, you lose the patient. So it's trying to figure out where to fit it in. So Ellie, how do you figure that out? How do you know now's a good time? Or this patient's drinking 2 glasses of wine every night with dinner. What do I say?
I'm very careful about reading the room because this might be one of the worst days of their life. And I'm not trying to take away any coping mechanisms. You have to be very mindful of how much pain these people are going through on that day. But I usually let the patient direct it. And 9 times out of 10, they say, what can I do to lower my risk? And the second they say that, then I go down the route of weight loss, minimizing or lowering alcohol, daily movement, stuff like that. And then I tailor it to their stage of life. So yes, if it's an 80-year-old, we're going to talk about walking. And if she has her glass of Chardonnay with her friends, however many times a week, and that's giving her life, great. But last week, this poor girl's in her 30s and she's completely beside herself at why this happened to her, what she can control. And so she was the perfect patient to talk about alcohol and obesity and all of those factors. You have to be really thoughtful of who you're talking about this with. And you also have to meet them where they're at and kind of see what they're ready for. I don't talk about this with every patient at all. It's really the ones that bring it up and are ready for it. Otherwise, it'll be kind of in a follow-up appointment or in a survivorship role where we're kind of talking about these other kind of lifestyle things.
I think for our high-risk breast cancer patients, it's absolutely important there. And then even with some of my breast cancer patients, I seriously had one patient who went home, drank a bottle of wine, tripped, fell, huge lac across her forehead, and had to see the plastic surgeon early. And I was like, well, that's one way to get that stat consult. And so you can use that in those experiences as humor when you know someone's on that edge and if that's kind of their coping. But Susan, you're exactly right. Like reading the room and how do you reach people? Lots of people have done things that can sometimes be dangerous, and it wasn't going to be the alcohol that killed her, but the head injury. So we don't want that either.
I very much tried to stress at that initial visit sort of what's going on right now and where are we going in terms of treatment. I have had patients where I find that they really want to direct the conversation. Why did I get this cancer? What did I do? Mm-hmm. And I think one of the important things there is even though there are many modifiable risk factors, we are all born with an inherent risk of developing different types of cancer. I always tell the story about my grandmother who smoked unfiltered cigarettes and ultimately died of a smoking-related complication, but never developed lung cancer. And so I really try to redirect that initial breast cancer consultation to where are we right now? What do we need to do in terms of treatment? And I like to focus the survivorship visit on where we are moving forward and really try to direct that. But I think going back to talking about high-risk patients, one of the things we talk about in the breast surgery community is, do you see a lot of those patients? For the most part, I don't see high-risk patients as a breast surgeon. So we have a high-risk program in my facility that is run by medical oncology. And I don't think there's any one right way to run a high-risk program, but I think different people staff it. So do you guys personally see a lot of these high-risk patients? How often are you having these conversations?
I do. We have a high-risk program. It's a joint venture between medicine and surgery. We also have a survivorship program, and I'm fortunate to have that program, but glad that things like lifestyle modification and risk reduction are discussed within the survivorship program as well. One thing that I don't discuss that I want to, because I think the evidence behind it is very compelling, is vitamin D deficiency and its role in mitigating risk. Do you guys talk about this with your patients? Do you check vitamin D levels?
Yeah, we do. And you're right. The evidence is fairly compelling. Those women with below normal vitamin D levels have a higher risk of breast cancer and a higher risk of recurrence. And just maintaining it within a normal level seems to certainly not erase the risk of breast cancer, but it certainly improves it. So, I mean, those are pretty easy things to do. You can get what you need to help with that. And it's a simple lab test to see where you are in that. We're not outside anymore. I think that's one thing for sure that seems like an easy fix, but there's pretty good data on that.
So is it causal? Do we know that from the data? We know that a minimum of 25% of the population has low vitamin D, at a minimum. Now, many insurance companies have stopped paying for vitamin D testing, which if insurance companies aren't paying, then clearly fewer people have that done. But is it definitely a causal relationship, or is it true, unrelated?
That's the problem with this field of mitigation completely, because there's so many factors that play into it. You may not smoke or drink, but maybe your diet is so abhorrent that that's what's going to cause your cancers. It is hard to isolate these individual features out when people live 50 years, then get a cancer, and hard to pinpoint what it is that caused their problem.
So let's talk about something that we know is causal, and that's obesity. And when we look at the numbers in our country of people that are overweight, which some studies will say close to 70% and 40% are obese, and 9 to 10% are severely obese or morbidly obese, it's an epidemic. And how, as physicians, are we changing that? How do we counsel our patients? What do we do about it?
This one is really hard because I will go back to that conversation of the woman who's newly diagnosed with breast cancer, who may be overweight and has probably been working on diet and exercise to fix that, and now has been diagnosed with a breast cancer. And it's not a great time for the conversation. None of us want to have the conversation of I need to lose 5 or 10 pounds. It's really, really, really hard, especially for women as we get older. So I think it's great that we as breast surgeons talk about this, but with primary care physicians and GYN and people who are seeing women and men growing up and sort of talking about it. But we just really need to emphasize to people the role that this plays. Many, many, many years ago, one of the journals, it might have been Cancer, but they had an obesity journal that was totally dedicated to just the different cancers that are related. They estimate about 5% of cancers in men and about 10% of cancers in women are related to obesity. My guess is that number is actually probably a little bit higher. Breast is one of the big ones that is associated, and you mentioned before, with postmenopausal breast cancer.
Yeah, I agree, Carla. I really just think the more we educate the public, maybe this isn't that one-on-one time at diagnosis, but this is how are we interacting in the community and doing these events and educating our primary care colleagues and our friends and our acquaintances of knowing these risk factors. And I think it's also having that conversation. I remember when I was on my family medicine rotation early third year, and this person came in and she weighed over 300 pounds and told me her knees hurt. And I was like, well, you know why your knees hurt. And I almost failed the rotation. But she was like, no one's ever told it to me like that. And I was like, I could not literally carry that around. This doesn't define you, but this does contribute to why your knees hurt. What is it we can do to help you? And it is very true. There's a lot of people who have done all the right things and they have a calorie restricted diet and they exercise and they still have trouble with weight, and figuring out how to hook them up with our colleagues who can really help them.
Does anyone know how many cancers obesity increases the risk of? It's a shocking number.
Is this like Jeopardy?
There's like 5 different cancers, I think.
No,
right?
I think it's 10.
13 cancers are proven to be at increased risk due to obesity. I mean, this is really an epidemic, and we never want to blame the victim. So when somebody comes in with breast cancer, it is never their fault. Ever, ever, ever. Our primary care colleagues honestly cannot have one more thing on their plate that they are responsible for. I have no clue how they get everything done in that short amount of time of that visit. So how do we get the word out? How do we educate people? Because we can't put everything on primary care. It just doesn't work. So how do we change society?
I think the word is out. I think what we've learned is that a lot of the food that we eat is very addictive. And so I think talking about diet is important. I'm sure you guys get asked a lot, should I be a vegan? Should I be a vegetarian? I've had a couple of patients who are vegan who wonder, I'm vegan. How did I get breast cancer? I tell people that a diet high in plants, vegetables is very helpful, and minimizing meat intake is important. It's not very prescriptive because how much meat is a lot of meat, but I definitely try to focus on a plant-based diet as much as possible. What about you guys?
So Carla, being so data-driven as you are there great studies showing that we should reduce all sorts of meat in our diet? Because Michael's trying to sell his cow.
Oh, yes.
And you're really
hurting
the nasty look. You're hurting his business here. So are there great studies showing this?
Those studies are almost impossible to conduct. It's easy to be like, you take this pill and you take this pill. But if it's like, well, what did you eat today? And what did you eat today? It's very difficult. So no.
But there is some compelling research suggesting that a Mediterranean diet, again, not causal, but it can contribute to a lower risk of breast cancer, especially after menopause. I think the data is there. I don't think you're ever going to find that one-to-one association. I think that's part of the problem with epidemiologic studies. But with that being said, I think we can comfortably, as professionals, state the benefits of this.
I don't get prescriptive with the patients. I think we can all agree on a few things, like processed foods are bad, fast food, bad, leafy green vegetables are good, organic vegetables are good. And so I really try and kind of explain those simple terms because, yes, a lot of them do get caught up in, should I be vegan? Should I be paleo? Should I do keto? I don't know. And I just tell them to like shop around the edges of the grocery store. Don't go in the middle where there's things that have boxes. Try and get meat from the best source you can. Try to go to your farmers markets. Try and get stuff from your local farmers. Shout out Michael. Try and get all that stuff. It's super convenient to go to McDonald's. It's super convenient to drive through things. So our whole world is not set up for this. So I think especially as surgeons, we need to kind of break through all the noise because there's so much content out there. We have to make it simple for them. That's how I'm able to get through to them on that. And then once they hear that, they're like, okay, I don't need to go crazy with all these different diets. And they can kind of make these tiny adjustments at a time. But a real fact is the hormone blockers that we give them for recurrence prevention, those cause weight gain. And especially in women that they're not expecting. Tamoxifen and anastrozole, they do that. And so I do think we need to, in some ways, address this with them and not just leave it to the medical oncologist and try and give them bite-sized pieces of actual things that they can work on. And then what I personally do is I try to find people in my network that I can connect them with that do have the resources that can help spend hours with them to go through it with them. Because that's what it takes, right? For them to actually make a meaningful change.
Ellie, I like what you said about the processed foods. And I think seeing where people are with different socioeconomic backgrounds and trying to give things that are realistic and that it is not a no sugar diet. Or I once had someone who was trying to eat 10 pounds of kale a day. And I got like so sidetracked on like, how much kale is that really? I mean, like kale to me is kind of light and like that's a huge, and how do you source that? And I just kind of went off on all these things, but it's not one particular thing, but being well-rounded and not overdoing any one thing is really helpful.
I'm just learning about this concept of a food desert. So a food desert, it's a geographic area where residents have limited access to affordable and nutritious foods. And it's often associated with low-income neighborhoods. A lot of my patients really can't afford some of the healthier eating habits that we discuss. And I'm just curious, how do you approach that?
One of the things I remember talking about at one of our ASBRS conferences was there's a role that we each play as individual doctors and surgeons, but there's also advocacy, politics in terms of how food deserts occur. And I'm not going to get into politics here, but I'm just saying that some of these things we cannot address on a one-on-one basis sometimes. And I'm sure there probably are some good solutions one-on-one with patients, but these are really big picture things that we have to be thinking about in our communities because they are real issues. And I think it's hard for us as an individual doctor to address some of these things. And I like to address the things that I know I can affect change on. I think that's part of why many of us are surgeons. And I think some of those things are really challenging. But getting into somebody's food and what they eat and what it costs, I think is incredibly in-depth.
But I think there's a real sense out there that people are waking up to this. It is going to take probably some governmental action that kind of got us here with the old food pyramid. Maybe it's time to rethink what we thought was the right way of handling this and what is nutritious and what can we eat and what should we eat. If the public wakes up to that, then hopefully the politicians will wake up to that. I think you'll begin to see some of these things change out in the community to where chicken tenders are not considered the most healthy of the things that we should be eating or feeding our kids, but maybe something else. And it's going to take a bit. We didn't get here overnight. We're not going to fix it overnight, but I think there's some real awareness and a real desire to change. Well, believe it or not, we're just about out of time. But before we close, let's go around and have each of you share one thing that we can take away from the episode. Let me start with Ellie.
the concept of timeliness and meeting your patients where they're at and keeping them at the forefront of your visit and, not always trying to push your agenda and just trying to meet them where they're at and help them.
Carla?
Life is a balance as well. We've talked about a lot of the things that you can't do. We talked about alcohol. I love a good glass of wine. And we have to kind of balance the enjoyment that we have with some of the things that we do with the risk. That is different for each patient and each person. And yeah, life is a balance.
Sitcha, what are your thoughts?
I think the takeaway for me is that risk can be mitigated. We focused on primary prevention and mitigating risk. It's never too late to talk about risk reduction.
Susie?
I think I learned that I can't do all of this. This would be a 10-hour office visit, and that it's so important to figure out what are our community resources. And then, like Susan said, reading the room and then saying, hey, do you want more help with that? But in advance, knowing who is better at that to walk through, I can start that conversation and knowing that I have support that will also be out there to help the patient. And I can touch base and be like, hey, how is that going?
Susan, what's your take home on all this?
Life is a team approach. We can't take care of a patient individually. I need the rest of my team, and I can start this conversation, but I need the support of my social worker and my nutritionist and my physical therapist and everyone else to help this patient. But I do believe that life is about moderation. I don't think that we can say to someone, never have a drink, exercise every single day. I think it's about moderation and meeting them where they are and helping them along, but remembering we have to walk before we run.
This is incredibly insightful. Thank you guys for your input, and to our listeners throughout the breast community. We're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
Sitcha,
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.